I had the pleasure of introducing Dr. Christos Argyropoulos, who is an associate professor and division chief of nephrology at the University of New Mexico School of Medicine and deputy director of the Southwest Center for Advancing Translational Innovation. He trained in internal medicine at the University of Cincinnati and in nephrology and transplant nephrology at the University of Pittsburgh Medical Center. He is a clinical and translational science researcher with interests in biomarkers of kidney disease and in electronic health records and other big data analytics. Dr. Argyropoulos will be discussing effects of repeated vaccinations versus COVID-19 on patients with kidney disease, focusing on both non-immunological and immunological conditions. Dr. Argyropoulos, the floor is yours.
Thank you so much, Dr. Kavanagh. Yes, the focus of today's talk will be discussing vaccinations and infections and kidney disease outcomes. No disclosures for this talk. In the next 40 minutes or so, we'll be discussing a series of large-scale electronic health record analyses that our teams did to try and understand the impact or lack thereof of repeated infections and the safety of vaccinations upon kidney-specific outcomes. As we discuss these 7 different analyses, we'll be also discussing them in the context of other findings in the literature, see how plausible the data that you get from an electronic health records are or not. And finally, the last couple of slides will be going over implications for public health and actually health expenditures, if these patterns that I'm going to describe to you today are true and if they persist. So these are like the 7 different projects. They were all presented in the American Society of Nephrology meeting 4 or 5 months ago, and they relate to different aspects of kidney disease. So we have data discussing acute kidney injury, sudden drops in kidney function in patients in the general population, as well as transplant recipients, long-term trends of kidney function in both in the general population and kidney recipients. Discuss 2 rare kidney diseases that are actually, I feel, provide some signals about the pathophysiology or the exposures at the population level, and recognition or just a mention that COVID is still pretty much a thrombotic disease or thrombotic predisposing disease, and discuss a particular thrombotic complication that's relevant to people who are receiving hemodialysis. The data sources for this come from an electronic health record aggregator that's called TriNetX. It's one of the largest data sources where healthcare institutions, both inside and outside the United States, contribute electronic health record data. They have a very convenient way to construct cohort and do limited analysis on their website. In fact, there are numerous papers that actually just did that. For very simple analytics, you don't need like software. It's a mouse-driven activity, generates a very nice description of how the cohort was described, and basically you can use that for methods. Our group is privileged to be able to access patient-level data, meaning not just what you can do on the website, but effectively dumps of the electronic health records on millions of patients, which allow us to do analysis that's kind of not possible to do with dragging the mouse. And for all these projects, we had a very simple strategy. Like, we asked the interface to find us individuals who have had a COVID test or a COVID vaccination documented in the electronic health record. And if they did, they became part of the cohort, and the entire history, meaning history before the pandemic started, became available to us. Now, from the get-go, there are 3 limitations that you need to be aware of, and these limitations apply to every single electronic health record analysis. First of all, people who tested at home and never presented to a facility to have a test will not be captured unless they decided to go and do a confirmatory test. Tests that are run in facilities that are not part of TriNetX are not captured. So someone who went to Walgreens would not have their test recorded there, but if they also at some other point in their lives went to a healthcare facility for a COVID test or a lab that contributed data, then they would be captured. So we have some misclassification about how many infections people may have had or the timing of the first infection. The third limitation is that vaccination records may be incomplete. Now, most electronic health records are set up to talk to state systems that document vaccination. So at some point, the data become available. But as it stands, there's delays between the time a vaccine is done and the time it's recorded in the electronic health record, which means that periodically you have to run updates to get more complete data. Now, one of the things that are sort of interesting about these type of analysis is that if you have a healthcare conditions, for example, kidney transplants or some form of kidney disease, you are more likely to be represented on an electronic health record. So if you are doing an analysis that's talking about the general population, where you want to analyze kidney function in people who are healthier, you have to make sure you don't contaminate the data, especially with transplant patients who tend to have labs every 1 month or so. And as you will see when we describe the data available, they have a considerable number of kidney function tests in the system. So how do we do those analyses? And this is important to spend a couple of time talking about these issues. For rare events, and by that I mean the two rare kidney disease, some of the acute kidney episodes of the thrombotic events, we relied on a methodology that's called self-control case series. This is the main methodology by which you analyze vaccine safety. So you have an exposure, either a vaccine or an infection, and then you look at the timing of particular events of interest in relation to the vaccination or the infection. And the period before that is used as a control. And this is the accepted methodology to analyze data that cannot have a control. So, and we follow that, especially for the rare conditions. For analysis as for common events, so for example, and as you'll see, our data go from a few hundred patients to millions of them. We relied on more traditional methodology in which every patient entered the cohort, and then we used all the repeated measurements to understand what's happening over time. So that's the realm of methodologies that's called mixed methods. Now, one of the things that happened in the last 5 or 6 years is that there has been a significant or substantial code maturation. So what do we mean by that? When you do analysis of electronic health records, you rely on a combination of standardized codes that come from the ICD-10 system and lab data and vital signs to do your analysis. The codes tend to be used inconsistently, and certainly for some conditions, the frequency by which they are used increase over time. That's like the phenomenon of code maturation. The reason I mention this is because you can't really use any of the data to sort of ask questions such as, is this condition getting more frequent? Our data cannot answer that. The only thing that they can answer is, are certain events more frequent or temporally related to an exposure of interest? So with that, let's start with the smallest data set, the rare kidney disease. So the first condition we're going to talk about is called C3 glomerulopathy. C3 is a protein that comes from the complement system. It's considered one of the rare diseases, so there's about anywhere from 0.2 million to 2 cases per million population per year, so it's a very rare event. It affects children as well as adults, women and men equally, and the characteristic feature is that within 10 years, half of the individuals will have lost their kidneys and be on dialysis. Now, why do we call it C3 glomerulopathy? If you end up doing a kidney biopsy, then you will find that the kidneys have a certain pattern of injury where there is deposition of material inside the glomeruli. Those circular areas are the filtration units inside the kidney. We call it glomeruli. And if you stain them for the complement protein C3, you will find that there's a lot of C3 in those lesions, but if you stain them for immune globulus antibodies, you will find that there is none. And this is like one of the differentiating features of this condition versus post-infection glomerulonephritis, like things that people used to get in the 50s before the antibiotics, where you had both antibodies and complement, lots of cells infiltrating the kidneys. The reason that this disease is important is because until like a couple of years ago, it really had no therapy. We tried various immunosuppressive therapies with variable success. And in the last 2 or 3 years, we have approved therapies that target complement activation that are extremely effective, but come with a price tag of about $500,000 a year, lifelong. So this is the consort diagram. You're going to see versions of this over and over again. But, we started with about 15 million individuals. This is data pool from March 2020 to 2024. For this particular case, we excluded people outside the US, people without ages. We used the diagnostic code for C3GN, and we ended up with 226 patients. Now, we found that some of those cases were patients who had received a kidney transplant, so perhaps they already had the disease, so we decided to exclude those, and we ended up with what we believe were 115 patients who developed this C3 glomerulopathy after 2020. Now, this was where we start analyzing the data in time. So we found that if you look at the appearance of a new N0 star.A, that's the ICD-10 code that's used for this condition, there was no temporal association between the appearance of this code and the vaccination, meaning you were not more likely to have a code like this appear after a vaccine versus before a vaccine. Having said that, there was an increased risk of having such a code following a COVID-19 episode, which is defined as just having a positive test recorded in the EMR. So the relative risk, the increase in frequency is about twofold compared to the time before having an infection. Again, one of the major limitations here is what I call the code maturation problem, is that this code was introduced just before, slightly after the pandemic. We are increasingly using these codes to mark those patients in our electronic health records, so therefore you can't really say anything about frequency here. Just notice that it's more likely to be recorded after an infectious event. As a result of this, you probably cannot say with certainty that the disease is not associated with vaccination. What you can only say is that it's more likely to be associated with infection than vaccination, and the signal for the vaccination is probably close to non-existent. Now, one of the questions when we looked at this data is, okay, is there a chance that we are looking at false positives? Is the association of C3 disease with COVID-19 a false positive? Now, if you go to the literature, you will find that there are numerous case reports on both the adult and the pediatric side, on the general and in the transplant population, that clearly document that these are like complete case analysis. It's not just an abstract analysis on a database, that they had the data, these were their patients, they knew their exposures, and they make a very strong case that this association is not a false positive. A COVID-19 disease episode can be associated or lead to severe glomerulopathy. Having said that, there is also some case reports that say that this may also happen after vaccination, and these are like examples of associations with case reports really in the literature. A couple of them, a paper in clinical nephrology, actually went deeper and started sequence the case, and they found that they also had 1 or 2 mutations in complement genes or genes associated with activation of the complement. So maybe there was, the traditional model of an exposure and on a genetic background that led this. So one has to keep an open mind, but it seems that just looking at our electronic health data, the association seems to be with the disease itself, not the vaccination. When you see something like this, the next question you ask, is this epidemiological signal even plausible? Does it happen? Or, is it a fluke? So it pays to understand a little bit what the complement is. It's effectively an ancient system of proteins that are circulating mostly in the serum, but also in some mucosal surfaces that defend against infections. The complement can be activated by a number of different stimuli, what we call the pathways. You can have like antigen-antibody complexes, exposures of surfaces, but there is also what we call the continuous activation of the complement, because the protein itself, the C3 protein, undergoes a continuous turnover. So there is always a little bit of complement being broken down, then formed. And this is the pathway, the alternate pathway that we will focus on. In C3 glomerulopathy, and we know this from investigations on the disease itself, we have a predominant activation of the complement in the fluid phase, meaning in the circulating plasma or serum. Whereas if you activate on the surface of blood vessels, you cause something that's called the atypical hemolytic uremic syndrome or thrombotic purpura. But we're not talking about those conditions. So the C3 association is real. Then it's mediated through activation of the complement in the fluid phase. This is a review from about 2021. It was written at the time where ICUs were full and when there was a lot of respiratory disease around. And it's a very nice review that effectively shows how SARS-CoV-2 can activate the complement system. Back those days, respiratory disease was very, very prominent. So there was a focus on what happens in the lung cells, the pneumocytes, but there was a lot of data, even like 16 months or 18 months after the pandemic started, that clearly showed that you can activate the complement through a number of ways, including damaged blood vessels. This is a review from about 4 months ago. And the review now is about the complement in long COVID. As you can see, the picture is very, very different. People just speak about mechanisms like immune dysregulation, persistent viral infections, autoimmunity. Don't get this extensive blood vessel damage that we're seeing early. And there is a table in that paper that includes about 6 different studies of individuals with long COVID, with measurements of the complement that show activation of the alternate complement pathway, the one that should be activated in the cases that we analyze through the electronic health records. So there is clear evidence outside our analysis that complement activation does happen during COVID, and it doesn't take a lot of belief or leap of faith to see that the associations we found on the electronic health records are causative. Let's switch gears now to something called IgA nephropathy or IGAN. This is the most common primary kidney disease. The most common kidney disease in general is due to diabetes, but IGAN is the most common primary kidney disease, meaning you're otherwise healthy, it's your kidneys that are at fault or at risk. It's a very different epidemiology from C3GN. For starters, its incidence is 10 times higher or 100 times higher than C3 glomerulopathy. It's a disease of primary importance for young individuals because it's the leading cause of kidney failure in those younger than 40. It's clearly recognized as a post-infectious or post-vaccination complication. This is one of the 2 risk factors that you read in textbooks and textbooks that preceded like 2020. And the reason that this disease originates is because there is a dysregulation in the handling of the IgA antibody class. IgA is the major antibody class in the respiratory system and the GI tract, and it plays a role in protecting those from infections, inducing tolerance, and in the gut, like making sure that the right bacteria, the right microbiome persists. It's also a disease that's very expensive to treat. Again, until about 2 years ago, or a year ago, actually, the disease itself was treated with a combination of steroids. Those therapies were partially effective. Then complement inhibitors, similar to what we have in the cystic glomerulopathy, came into play, but also a substantial number of other therapies. So IgA in the last 3 years went from a condition that had 0 therapies to a condition that has 6, and another 10 or 15 are in development. And if they get approved, they're going to be extremely expensive. So keep that in mind because of the numbers that you're going to see. Again, looking at the price tag of about $500,000 a year, lifelong. I think we should probably talk a little bit about how the disease manifests because it's important to understand some of the data, the literature data I will show about. So traditionally, there are 5 different clinical phenotypes of this disease. People can present with pain, less blood in the urine, what we call asymptomatic hematuria, with or without protein, with a kidney function that may or may not go down. That's the most common phenotype. You can have a second phenotype where individuals come to our attention when they develop an upper respiratory infection, and then they develop visible blood in the urine. A group of people can have rapidly progressive kidney failure, meaning that they lose their kidney function fast. People can present with lots of protein in the urine, what we call the nephrotic syndrome, and then you can have a subset of individuals that just come to our attention with acute kidney injury. There is no clear precipitant. We do a kidney biopsy and we find the IgA. The way the disease starts is also fascinating. We believe that there is a dysregulation of the production or the handling of IgA at the mucosal surfaces. And by mucosal surfaces, we mean the respiratory and the GI tract. An abnormal glycosylation pattern of the IgA develops. The circulating IgA then lodges into the kidney where it activates the complement, and then over the course of many years, you lose your kidney function, you end up on dialysis or need a kidney transplant. How do we approach the IgA disease? Again, similar concept. I'm not going to go with the numbers. We start with about 15 million individuals. We exclude people who may have had it before the pandemic started. We end up with a consort of about 605 individuals. Since we had a lot of data or more data here, you can actually do this a little bit more detailed temporal modeling. So you can use the period before vaccination or before an infection as a control, and you will see that, if anything, vaccination may be associated with reduced incidence of IgA. So the relative risks are below 1 and they're very close to 0. But if you look at what happened with the COVID-19 episodes, in the first 3 months, you have a signal that appears to be like a protection. We think this has to do with how you artificially cut the data set or the observation period to 90 days, 90 to 180, and 180 and beyond. This is a limitation of the self-control K-series methods. How you cut the time may affect the estimation of the relative risks. But after 90 days, there is a signal that seems to be in the direction of a higher incidence of IgA after COVID-19 episode. Is this signal real? I will argue that the signal is real, and it has been seen at least once before. And for that evidence, we need to travel to Japan. IgA is extremely common in Japan. They have screening programs for this. And one of the clinical symptoms that prompt an immediate investigation is someone walking in a clinic complaining of blood in the urine without pain and without evidence of kidney stone. Those individuals are sort of like saddled very quickly for an investigation. to make sure that they don't have an IgA. So in mid-2024, there was a national cohort study reported in Japan that asked the question, what happens with macroscopic hematuria? That's the clinical sign that may signify the presence of IgA. So there were a bunch of clinical study centers that pulled their cases together and they asked the question, what are we seeing here? So this is the visual abstract. They had about 100. They had patients with new hematuria after vaccination, so 127 cases. Many of them had pre-existing IgA, so IgA may trigger a recurrence. And many did not have a prior diagnosis, meaning they didn't have a kidney biopsy that they had IgA disease, but they have had histories of blood in the urine that have never been investigated. So it's kind of interesting that in those cases, 94% develop a gross hematuria within 2 or 3 days of exposure. It lasted 2 or 3 days for 3/4 of the patient and then went away. So this suggests that it's also vaccination or the immune activation that plays a role into this. Now, interestingly enough, if you look at the data, the animal data for the RNA vaccines, and we're talking about publications that happened in April or May 2020 in journals like Nature, Science, and Relatives. If you go to the supplement data, you will find that the vaccination itself does induce an IgA production. The virus will do it as well. And in fact, we want those vaccines to induce IgA because we want the vaccines to protect the mucosas. But in some individuals, side effects may develop, and this may be one of the side effects. Again, we didn't see it in our data, but it's important to sort of keep an open mind that some individuals who will come to our clinics clearly said, I never had COVID, or my last COVID was many months ago. I got the vaccine and I developed this. And we've also had patients who came to our clinic after COVID with lots of blood in the urine, and then we found IgA. So keep that in mind, again, that our data suggests that if anything, infection is much worse than vaccination. Now, there is a big cohort study that's been running in the US for 10, 15 years or more. It's called the CURE-GN study, which basically tracks people with various primary kidney diseases and has done so for many years. In that data set that's been running its observational course for a long time, they were able to track new infections and actually vaccinations and the effect on the development or relapse of the disease. Some of the author byline, there are people that I work with closely at the American Society of Nephrology and other diseases, or they've been friends for like 15 years now. So this is a stellar group of investigators. So this is the diagram on the right, will give you the infections, the COVID infections over time, and they superimposed the cases in the US population. And you see very similar patterns. Kidney patients are not protected or not more likely to get COVID-19 than anybody else. Interestingly enough, they found that vaccination was not associated with disease worsening, but COVID-19 was associated with increased risk of having higher primary kidney disease activity. So the relative risk was about 35%. Keep in mind that their analysis was not a temporal one, so the way the follow-up works just estimate the static hazard ratio, and I point out that the hazard ratio that they report is very similar to what we see in our analysis few months out, which is sort of the relative risk seems to stabilize. So something to think about. Let's switch gears to the big data now. We spoke about the small data. Let's talk about the big ones. And now I would like to switch gears and talk about acute kidney injury, or AKI, as nephrologists call it. This was a major feature of the early 2020-2021 COVID-19 experience. If you remember when COVID arrived in New York, they ran out of dialysis equipment, really, and they had to do things like portable dialysis machines, which is also something that we did in our institution, peritoneal dialysis, or just triage who got therapy. So it was a severe manifestation of the early COVID cases and often seen in individuals at the hospital. We know that many patients who get a COVID now, primary care infection, you get it, you are at home, but individuals may still get labs and they may still go to the hospital. So we have a way of tracking all those repeated measurements of kidney function that people get for various reasons in the electronic health record and see if we can identify individuals with acute kidney injury. The nice thing about AKI, and I'm talking in the epidemiological sense, in the sense of generating data, is once you get an acute kidney injury, this may trigger diagnostic investigations or diagnostic cascades that may alert you to the possibility of other symptoms. I point this out because AKI can be a way of accessing or analyzing complications that may not have come to our attention without it. But in the context of our analysis, again, you cannot say much about the frequency. It's only temporal data that we analyze. For this analysis, we started with 14 million individuals, and we end up with something substantially larger. But first of all, let me talk a little bit about how we diagnose AKI in this electronic health record. So we look at every single measurement of kidney function based on the creatinine. We compare it to the previous value, or what we call the baseline for each patient, which we establish as the first kidney measurement in the data set, or the last kidney measurement in the pre-2020 period for individuals who had been on observation before the pandemic started. Once we detected a significant change based on established criteria, we set up a clock and we started tracking those measurements over time until about 3 months. By that time, if the value had not returned to the previous baseline, we said that the patient was left with some form of kidney dysfunction. We reset their baseline and the clock and then tracked them again. And we did this for about 3 or 4 years. For this particular analysis, it's not enough to analyze the relationship to COVID-19 disease or the vaccine. Many respiratory infections will be associated with changes in kidney function. Influenza is a good example, and many individuals who get influenza in the hospital end up seeing a kidney specialist as a result of that. So for this particular analysis, we also included into the equations that estimate risk the presence or the time from a respiratory panel test. So basically, there are like 3 things that we analyze: timing in relation to a vaccine, timing in relation to a respiratory test, which can result in any number of different bugs being detected, and time from COVID positive tests, because respiratory tests can yield positive COVID results. We started, as I said, with about 14 million people when we excluded individuals without measures of kidney function, individuals with too few kidney measurements to analyze. We required at least 2, for example. We ended up with about 3.2 million individuals, 32 million measurements of kidney function for us to analyze. The table shows you how you diagnose acute kidney injury. So it's based on relative changes of the lab test that's called creatinine from the previous value. So you classify AKI to stage 1, mild, 2, moderate, 3, severe. Most of the individuals in our analysis had normal kidney function at baseline. So their GFR, which is a mathematical transformation of creatinine to a level of kidney function, was 91. Normal is about 100, but in general, we don't diagnose chronic kidney disease unless it's below 60. So if you look at the spread, on average is 91 with a huge variation. The age in the cohort was about 55 years old, and this is kind of significant because we lose about 1% of kidney function a year after the age of 40. So, if you just correct for the age with the eyeball test, you're going to see that most of the individuals had age-appropriate levels of kidney function. In these analyses, we had nearly 1.4 million episodes of acute kidney injury. So stage 1 was the predominant one, stage 2 was 7.4%, and only 1.4% were stage 3. As you can see, this is like a summary statistics of how many episodes per participant, how many vaccines, how many COVID tests. If you notice, there is a huge discrepancy between the number of COVID tests, which on average was 1.7 per participant, and the number of positive tests, which is 0.54. Most of the respiratory panels are not due to COVID. So when you analyze something like this, you want to make sure that you are capturing effects of respiratory infections that are not COVID. And this is what we found. In this analysis, since we have a lot of data, we can do something a little bit more sophisticated. We can count the number of prior infections and also analyze the time from the last infection. And this is how the data were analyzed. But we did this not just for the infections, but also for the vaccines and the test. So we can see in this data that the first couple of COVID infections are not associated temporally with a risk for AKI, but after the third one, there is a 4 to 8% higher rate of having an AKI. That's kind of concerning. It's a small number for sure, but when you're talking about millions and millions of people, small percentages multiplying with large numbers gives you very large numbers. Interestingly enough, no signal with the vaccine, like absolutely nothing. But this is just the static pattern, like the analysis that just looks at the previous infections. What about the temporal data? And this is where it gets interesting. By the way the statistical models work, time zero, the time that you got a COVID-19 or a respiratory panel test or a respiratory infection, this is considered time zero for this temporal analysis. And then you look over time what happens to the rate of the event of interest, the acute kidney injury in this case. The vaccination, as you can see, reference is unvaccinated. Nothing really, like there is no temporal signal. It's stone cold 1. And when you are looking at 1.4 million individuals, you have a lot of power to detect a statistical signal. And there is nothing there. Now let's flip to the other two diagrams that describe the risk after a COVID test without tracking whether it's positive or negative over time. So the baseline is the day that you were tested for COVID. And one would assume that the risk is higher at that time because you're clinically ill, no brainer. So the risk is higher there, and over time the risk goes down, and about 50 days kind of stabilize, which is a little compatible with what we know about respiratory infections and acute illnesses from other infections. So you are more likely to get a change in the kidney function if that happens. Now look at the temporality of when the COVID test was negative. The risk is high at the beginning, so number is 1. Then it goes down with time, rapidly in the first 45 days, but then it continues to go down. This is a suggestion that the risk that you saw here, that you clamped at the value of 1, persists for much longer. And if you take the usual baseline, reset all the graphs up so that the bulk of the values is around 1, you see that a COVID positive test is probably associated with 40% higher risk of acute kidney injury. And these are individuals who are not just in the hospital. So if you look at the relative risk of acute kidney injury in hospitalized patients, it's much, much higher. Now, we're talking about individuals who were outpatients or in the clinic, had standard labs for their general medical care, and we detected these changes in kidney function. Acute kidney injury is a risk factor for chronic kidney disease. We've known this for decades. So one of the questions, if you start probing transient changes or acute changes in kidney function, is what happens with chronic kidney disease, which is the more common form of kidney disease. In the first years of the pandemic, we know that individuals with various forms of kidney dysfunction experience the higher rates of clinical events and death. In fact, some of us at the beginning of 21 wrote letters and advocated for prioritizing individuals with kidney disease to receive the vaccines because they were dying at extremely high rates. My own clinic of patients with diabetes and kidney issues, I lost about 20% of my patients in the first year. So we know that chronic kidney disease is associated with bad COVID outcomes. We understand that there was probably something that's called the harvesting effect, with many individuals with kidney issues dying for the first few years of COVID, which paradoxically led to the dialysis companies' finances suffering because they had no new dialysis patients to deliver services to. But this analysis is important because of other changes that happened in the field of nephrology after 2020. After that year, we had the introduction of therapies that are extremely effective in slowing down the progression of kidney disease, reducing the need of dialysis, reducing the need of transplants. So if there is another source of kidney injury or kidney disease in the population, this will lead to many more individuals needing those therapies. We need to higher need of services for nephrologists. Unfortunately, my specialty is one of those where more practitioners are likely to retire in the next 5 years than new practitioners are to enter the field. So if there is going to be a tsunami of kidney disease cases, we'd like to know to plan our clinical services. So that was sort of the background for the analysis. But for this one, we were very interested in one particular point. What happens to the level of kidney function over time? As I mentioned, the average rate of loss of kidney function is about 1% per year after the age of 40. So if you change that dramatically, you may end up with more people with kidney disease a few decades down the road, and more people needing therapies, nephrologists. So it's important to know. For this analysis, we sort of said we don't want to be making the mistake of analyzing people who get labs while they're hospitalized. So we just looked at individuals who had outpatient lab values. And in the database we use, we can find out where the lab was drawn. Again, we start at 1.5 million people, exclude individuals with certain missing data patterns or individuals outside the US. We end up with about 1.6 million individuals. There is a higher variability in the level of kidney function here. So if you remember in the other in the acute kidney cohort was 93, here it's 87. When you're talking about millions of people, these small changes are actually quite significant. So we are capturing individuals who are getting kidney tests because of some form of pre-existing kidney condition. And that's attested by the number of measurements we had available. I mean, we've had on average about 6.6 measures of kidney function with a wide range. The minimum number is 2. Epidemiological good practices suggest for the type of analysis of trajectories of kidney function, you need at least 3 measurements. So we actually did have those values. It was like quality. The quality as far as this aspect was concerned was very high. And obviously we didn't, well, I shouldn't have said obviously, but for some people it wasn't obvious, but we had no deaths in the cohort. So these individuals were sort of like healthy. We had made sure we excluded hospitalized cases. And this shows that our quality control of the data for building this cohort was acceptable. Now, if you were ever wondering what a 7 or 8 million data points look like in paper, or in a graph, that's what they look like. So we did standard correlations of the same measurements of kidney function after the first COVID-19 vaccine and after the first infection. The graph probably takes about 45 seconds to generate and put in paper. It consumes a lot of memory, but it's kind of interesting to see some of the patterns in the data points. I'm not going to spend time on that, but there is signal on the cloud of points there that is reserved for a statistical audience. But what's kind of interesting here is the effects on the trajectory. So we are finding that before anybody got a COVID vaccine or an infection, they had an average drop of kidney function of about 1.36% a year. So that's a little bit higher than the 1%, again, suggesting that some of these individuals did have a kidney disease. That's why they were getting those values. And the statistical tests that are reported here report or analyze if there was a further change in the rate of loss after the first or the second or the third vaccine. And there was nothing there. Like, vaccinations did not appear to change how fast one loses kidney function. But let's talk about the infection. And this is where it gets extremely interesting if you're a nephrologist or if you're an epidemiologist in this space. After the first infection, it seems that the slope gets less negative, meaning people don't lose kidney function as fast. The same thing happens after the second infection. And on the third infection, the rate of change in kidney function is actually worse than before the individuals got any infection. Now, what does this data mean? If you're a nephrologist, this is a scary figure. It means that the two infections induced a physiological condition called hyperfiltration, meaning the kidneys were filtering the blood much more effectively. And after the third infection, remember, we're looking at data over 4 years, the pattern had reversed to the point that people were losing slightly faster kidney function. This diagram on the left is from one of the most famous papers in our field. It was published in the American Journal of Physiology in 1985. And it's a model that shows how people with any kidney disease lose their kidney function. So these are data from, I believe he studied rats. Brenner, that's the name of the nephrologist who did those studies in the 70s and 80s. So in the rats, you can actually measure how each of these million filtration units inside the kidney function. So this is called the single nephron GFR. So they put some capillary glass tubes and they can actually measure how much fluid is generated or urine is generated in those units. And as you can see, in the normal state, you have a very tight distribution of filtration of function inside the units. So this is like a level of kidney function of 100%. Then in these experiments, they induced kidney disease in these animals with various toxins or surgeries. And at the beginning, they found that they had like rats that had normal, on average, kidney function. That's what you get when you sample from the blood. But if you go and measure what each of these individual filtration units do, it's a huge spread. This 100% is maintained because some units are filtering much more and others are filtering much less. So this is the classical pattern of hyperfiltration. And over time, the units that are filtering the blood more effectively burn out, and then more and more of them die. That's the black chart. And eventually the animal and the human end up with kidney failure and need dialysis. Nearly every form of kidney therapeutic that's out there, like ACE inhibitors or angiotensin receptor blockers, medications like losartan and lisinopril that are now generic, work by blocking the hyperfiltration. So when you find that the condition induces this at a population level, at the detectable level, and then after 1 or 2 years, you see the pattern go away, you get scared. You should get scared because you may be seeing something like this. And there is a lot of molecular biology of how you lose kidney function. I'm not going to spend time on this, but it's one of those things that scared me when I looked at the data, and I hope that this pattern does not persist. Let's switch gears to something a little bit more technical, thrombotic events in individuals with dialysis. People who need artificial kidney treatments require accessing their bloodstream. We do that by inserting needles in devices that we call arteriovenous fistulas or grafts that are either natural, artificial, or artificial conduits that allow a vein to support much higher flow rates so we can extract the blood and we use that to clean it during dialysis. These devices themselves are more likely to develop clots. Actually, one of the most common things that we deal with in outpatient nephrology, like keeping those devices running. And the question is, if you get exposed to a virus that has known thrombotic potential, what does that mean? Do you see any signal of that? So basically, we're using these higher frequency events as a way to detect how is the population being exposed to a thrombotic setting. Again, not going to talk about the cancer. We start with 15 million people, end up with about 16,000 individuals with vascular access procedures. Again, very similar number of infections to the general population, about half per participant, and about 2.1 interventions. And this is where it gets interesting again. The same type of self-control case series analysis look at very finely at the risk of a thrombotic event over time, comparing vaccination and infection. Vaccination is kind of nothing. If anything, you may see a decreased rate of vascular access thrombosis. You get a COVID-19 episode, in 4 months, your risk of needing an access procedure to keep the fistula up and running goes up by anywhere between 1.5 to 1.8 times, suggesting again that COVID-19 infections, despite these individuals not dying, is a prothrombotic state. The transplant-19 COVID sub-studies, again, I will not run through all the slides, but it's very similar concept. We know procedures that identify, or ICD codes that identify someone as having had a kidney transplant. So in those analyses, we went to the same database, extracted the data, and ended up with a significant number of transplant patients. Transplant analysis of this order are usually single center, but with this one, we probably had access to 30% of all transplant centers in the United States. So acute kidney injury, any kidney function test, eGFR slope, just the outpatients. We had a ridiculous number here. We are talking about a ridiculous number of measurements of kidney function per individual. Like, for example, as you remember, in the general population, you may got 6 measurements of kidney function on average. Here you have something like 27. These individuals get kidney labs. It's like when I do see people in the clinic, I mean, I may not see them in the clinic. I want to see their labs. And some patients joke in the clinic about that, I'm here because of my labs. I said, yes. Anyway, so this is like the type of data we have. And let's talk a little bit about the acute kidney injury, because this is where it gets very, very interesting. I'm really trying to understand what the data mean. So talking about the vaccine, similar analysis, baseline is time 0. Maybe you get an increase in acute kidney injury after the vaccination, but the numbers stabilize after like 50 days. COVID-19 test, the risk is higher after the event, goes down, and then it stabilizes. It's about a 40% higher risk of acute kidney injury after someone needing a COVID test, which is very similar to the general population. But look at the temporality if the COVID test ends up being positive. So the risk is high at the beginning, it goes down after 50 days, and then it goes up again. Why is this? I don't know. Is it because the virus persists and then, after the initial recovery, then you have a higher risk? Is it because we respond to the virus by reducing the immunosuppressive medications and then people reject their kidneys? I have no idea, but this is the pattern in the data. Long-term kidney function, it's a very similar slope analysis, and this is where we need to start possibly having the conversation about vaccine safety. So, average rate of loss of kidney function before any vaccine or COVID, 1.4 mLs per minute per year, slightly higher than the general population. These are individuals who have kidney issues. The slope gets more negative, meaning faster loss of kidney function after the first vaccination. It's 0.3. But then other vaccinations or increasing vaccinations doesn't appear to make this go down any further. So that's a little bit reassuring. Maybe the statistical model can fully capture the resetting of the baseline, but this is what the data says. But if you flip to COVID-19 disease, the pattern is actually not the same. So you have substantially higher rates of loss of kidney function over time. If you assume that this is a fluke of the statistical model which couldn't track the baseline correctly, and this is zero, right? This 0.3, 0.4 is zero, then this number is still substantial and indicates that individuals who have had COVID-19 infections, transplant recipients, will lose kidney function more with time. And we give them transplants to keep them off dialysis, and they keep getting infected, and the kidney will last a lot less and more people will need them. So some take-home points and thoughts, because then I think we ran over. So, I wanted to show you how we can use or mine large electronic health records to answer various questions and really generate questions that should be answered by dedicated studies. We looked at two immunologically mediated kidney diseases. Both of them appear to be increasing frequency, at least not in frequency, appear to increase temporarily their frequency after the infection. At the population level, we find an initial hyperfiltration injury with accelerated kidney loss afterwards, even this small amount. We found that patients with COVID, either in the general population or in the transplant population, have higher rates of acute kidney injury. And these are data that are not the first year of the pandemic. And vaccines seem to behave a little bit differently in transplant patients than the general population. There are many caveats with this analysis. All the electronic health record studies have biases, but at some point the bias becomes immaterial, because if you have captured almost all the data, you're not sampling, you're doing accounting. And accounting has no bias. It is what it is. However, we didn't capture every single individual in the United States, so potential for survivorship biases, changes in the landscape of who gets tested, something called the visitation bias, which really has no solution for the electronic health records. The visitation bias is why some people come and have healthcare procedures and others do not. PCORI spent millions of dollars trying to understand this in various grants in the last decade. At the end of the day, there is some statistical solutions that people will always have issues with. But as I said, at some point, the analysis stops being sampling, becomes accounting, because everybody is captured. And I do point out that by the way we construct the cohort, like we can do another update. In fact, we did another one like last year, but then we had a change in the composition of the team. So the data from 2025 have not been analyzed. You can always do long-term follow-up of these individuals, very similar to the smoking studies, right? They captured individuals who smoked in the 60s at some point in time, and then they extended the follow-up, and the true impact of smoking became available. Some final thoughts on why I think this work or further work is important. And I would like to talk about money here, because this is the big elephant in the room for our healthcare systems. IgA disease is a disease that you get about 2.5 new cases every 100,000 patients a year. The prevalence, how many people are known to exist with this disease, is 10 times higher than that. If COVID-19 increases the risk by about 50%, we are talking about a prevalence that goes up to something like 3.5 individuals per 10,000 members of the population. Now, if you factor in the size of the population in the United States, that's about 35,000 more patients. Do the math, 35,000 times 500,000 a year for life. And I will not do the math for you. And there are many companies who will make sure that those cases are found. They're about, it's one of those disorders that will probably have like 10 or 15 drugs with the same price point and rationale to use them in combination in the next 2 or 3 years. So yes, we will make some of the pharmaceutical companies extremely happy and possibly very rich, but do our healthcare systems and insurance companies can handle those costs? Acute kidney injury is also extremely expensive to treat. I mean, just like doing the frequent labs alone, following them up, even if nothing happens, you do create a lot of work. But let's talk about the really big number here, which is the chronic kidney disease. About 1 in 7 individuals in the United States live with a form of kidney disease. If the data I showed you, the GFR slopes, increase this percentage by even 0.1%, so 0.1% absolute multiplied on a population of 350 million, that's another 350,000 individuals with kidney disease, which may need diagnosis and therapy. The gold or the emerging standard of care, which is combination pharmacotherapy, comes with a price tag of anywhere between $1,000 to $2,000 a month. Lifelong, there is no cure. You take those drugs for life. And then you don't need things like dialysis, you don't develop heart attacks, you don't develop strokes. It's a really good combination therapy, but it comes with a price. So multiply $1,000 a month with 350,000 individuals for years and do the math. I would like to close with a couple of thoughts about transplantations, because I was one of those who sort of in 2021 to 2022 wrote an editorial in the American Journal of Transplant arguing for boosters in this population. In our clinics, we ran antibody infusion clinics until they lost effectiveness for years. Our transplant center did not exclude patients from transplant if they refused the vaccine, because we knew from looking at the animal data, the vaccines will only temporarily block transmission. So I don't have a skin in this game. I've supported the vaccines. I've taken 9 or 10 of them myself. I've given monoclonal antibodies, but I'm questioning whether we really need to do a dedicated prospective safety study in this population or rethink prophylactic strategies and pivot to monoclonals. And there's only one monoclonal in the market right now, very effective, but has to be given IV. There are hundreds of thousands of transplant patients in the US. So, you can possibly say just like infuse them every 2 months or so, although we have run infusion centers for some of our patients. So at least for these individuals, we really need to sort of be asking the question, is the analysis I show you just a statistical artifact? I mean, after all, there were only 14,000 patients, right? Or is there something that needs further study? Perhaps we need to do the prospective safety study and dispel any worries. And in the meantime, for our patients, like perhaps within monoclonals. Thank you for your attention and for going over. I apologize.